everyone, welcome to Thyroid. This is Pack 365, myself Srija. Today in this session, you are going to learn about the CPT coding guidelines related to surgery respiratory system. So coming to guidelines regarding lungs and pleura. So what are lung and pleural procedures? So these procedures involve removing tissue from the lungs or pleura, which is a thin membrane covering the lungs and lining the chest wall, for diagnosis to find what a lesion is and for treatment to remove the disease. So the amount of tissue removed can range from a small biopsy sample to a part of a lung or even an entire lung. So what are the approaches used to perform this procedures? So lung and pleural biopsies or resections, they can be done using different surgical approaches. For example, for percutaneous approach, so needle pass through the skin, usually image guided CT or ultrasound, and used mainly for diagnostic biopsies. And second is thoracoscopic approach, VATS. So it's a minimally invasive procedure, small incisions plus camera, and also there will be a less pain and faster recovery in the patients, and which is very common today. And third approach is thoracotomy, which is an open chest surgery, and we have a larger incision in the surgery which is used for major resections or a complex cases. So the surgical approach often affects the CPT code selection, and there are types of lung biopsy techniques. So what are the types of lung biopsies? So they can be performed using different techniques. So A is incisional and wedge biopsy. So in incisional biopsy, only a portion of the lesion is removed. The lesion remains in the body and the purpose is for only diagnosis. Whereas coming to wedge biopsy or wedge resection, a small wedge-shaped piece of lung tissue is removed, which includes the lesion and surrounding tissue. So this can also be for diagnostic or therapeutic procedures. So what are diagnostic versus therapeutic procedures? So coming to diagnostic procedures, the goal is mainly to obtain tissue for diagnosis. There is no need for wide margins. Pathology determines the next step. And example is a biopsy of a lung nodule. And whereas in the therapeutic procedures, the goal is to treat the disease. It requires clear margins, complete removal of the lesion. And this is also used for tumors, benign or malignant, bleps, bullae, and cysts. So margins matter only in the therapeutic resections but not the diagnostic biopsies. And the next guideline is the extent of the lung resection. So depending upon the disease severity, surgeons may remove a small wedge, a segment, a lobe, or an entire lung. Sometimes adjacent structures like pleura, chest wall, lymph nodes may also need the removal. So now what is the important concept here? The wedge resection. So wedge resection can be either diagnostic wedge resection and therapeutic wedge resection. So diagnostic wedge resection, it is done to obtain the tissue. Margins are not the focus. If further surgery is needed, it remains the diagnostic. Whereas therapeutic wedge resection, it is done to treat the disease. It requires the clear margins and complete excision. So even if followed later by a larger resection, it is still considered as a therapeutic if margins were addressed. And next is intraoperative pathology, which is very important. So during surgery, tissue may be sent for immediate pathology. If pathology shows malignancy and more extensive resection is required in the same area, then the initial wedge resection is classified as a diagnostic wedge resection. So when a wedge resection becomes a diagnostic due to intraoperative findings, it is reported using CPT codes 32507 and 32668. So this is used whenever the wedge resection leads to a decision for more extensive resection in the same anatomic location. So when is a wedge resection therapeutic? A wedge resection removes the lung lesion plus surrounding normal tissue. So with intent to treat but not just diagnose. So in this wedge resection, margins were evaluated and there is no further lung tissue removal is necessary. So what are the CPT codes for therapeutic wedge resection? 32505, which is an open approach, and 32666, it's a VATS approach. So even if pathology confirms malignancy, if no further resection is done, the wedge remains therapeutic. And next, codes for lung or pleural biopsy or a diagnostic wedge resection. These are used when the goal is diagnosis only. So what are the common CPT codes listed here? 32096 for pleural biopsy, 3-400, 3-408 for lung biopsy, 3-507 for open diagnostic wedge resection, 3-607, 608, 609 for thoracic thoracoscopic lung biopsy, whereas 3-668 it's for thoracoscopic diagnostic wedge resection. And next is therapeutic wedge resection of lung mass or nodule. So this is used when the lesion is small and peripheral, the wedge removal is curative, and no lobectomy or segmentectomy is required. So the CPD codes are 3-505, 506, 666 and 667 for open wedge resections and VATS wedge resections. So coding always depends upon the approach, whether it's an open or it's a thoracoscopic approach, and the intent, whether it's a therapeutic or a diagnostic. More extensive anatomic lung resections. So these procedures, it removes specific anatomical portions of the lung. Types: segmectomy, which is a removal of lung segment; lobectomy, removal of one lung lobe; bilobectomy, removal of two lobes, either right lung only; pneumonectomy, removal of the entire lung. So this can be done via thoracotomy, which is an open approach, and also VATS, which is a thoracoscopic approach. So these are the definitive cancer surgeries, but not the biopsies. And next, coming to intraoperative pathology guideline. So what is an intraoperative pathology guideline? What happens? So surgeon removes tissue here, specimen sent for frozen section, and pathologist provides the immediate results. And what is the most important coding rule here? For example, diagnostic wedge, frozen section and lobectomy is done in the same session. So you have to report only the lobectomy here. Why? Because the diagnostic procedure is considered as an integral. So CPD does not allow separate reporting for biopsy, diagnostic wedge, and when followed by definitive resection in same location. So therapeutic wedge plus more extensive resection. So a therapeutic wedge resection is considered a part of a larger resection when it is performed in the same lobe or the same anatomic location. So CPD views the wedge as bundled into the definitive procedure. So therapeutic wedge codes involved here are 3-505, 506 for open approach and 666, 667 for VATS approach. So do not report these with lobectomy and segmectomy, etc. if it is done in the same lobe. And the exception is for different lobe or contralateral lobe. So if the wedge resection is in a different lobe or in the contralateral lobe, so it becomes a separative and a distinct procedure. So report the therapeutic wedge resection and you have to append modifier 59 so that the modifier tells the payer this wedge was not a part of the large resection. And the next guideline is the diagnostic wedge resection followed by more extensive resection in the same location. So how do you report the codes? So what happens clinically? Diagnostic wedge is performed here and the frozen section pathology is done. The surgeon proceeds to lobectomy or segmectomy in the same anatomic site. So what is the coding rule here? You have to report the most extensive procedure. So plus you have to add on the code for diagnostic wedge. So the add-on codes are 3-507 for open diagnostic wedge and 3-668 for VATS diagnostic wedge. So these codes are never reported alone. They must be reported with the definitive procedure. And the next guideline is regarding therapeutic wedge in a different lobe plus lobectomy. So you have to report wedge with modifier 59. What is an example? Right upper lobe lobectomy and a separate wedge resection of a lesion in the right lower lobe. So how do you code? You have to assign the code for lobectomy code and then therapeutic wedge code plus modifier 59. So there are no add-on codes here because the wedge is therapeutic but not the diagnostic. So understanding the VATS illustration. So here the image shows VATS, video assisted thoracoscopic surgery, which involve the minimally invasive approach, and there are small ports here and a thoracoscope, which is a camera, usage of a camera, and surgical instruments inserted through intercostal spaces. So the CPT codes differ from open approach as well as the VATS approach. So always check the operative note here. So next guideline regarding excision and resection. So what is excision and resection? Removing of all the lesion or an organ. So biopsy, it's removing a sample to diagnose the disease. So this slide focuses on the needle biopsies, not full removal. And here is a core needle biopsy, CNB. What it is? It's a thicker hollow needle is used. So it removes a core, that is a solid piece of a tissue. So why it's done? It allows the doctors to see the tissue structure under the microscope. It helps to diagnose the cancer type, infections and inflammatory diseases. And what is fine needle aspiration FNA biopsy? It uses a very thin needle. A suction or aspiration pulls out cells or fluid. So what is examined in FNA? Only the individual cells but not the tissue structure. It is examined by the cytology. So which is good for cyst, lymph nodes and thyroid nodules. Next is lung or mediastinum core needle biopsy. So these areas are deep inside the chest. So doctors can't just feel the lump. So they use the imaging guidance like ultrasound, fluoroscopy and CT scan as well as the MRI scan. Rare, this is very rare, but it is possible. So this imaging helps the needle go exactly into the lesion and avoid the lungs, blood vessels and heart. And what is the imaging guidance coding rule here? So codes like 76942, 77002, 77012 and 77021. So these are separate imaging guidance codes. So but when billing lung or mediastinum core needle biopsy, you have to assign CPT code 32408. So you do not report imaging guidance separately. Why? Because CPT code 32408, it already includes imaging guidance. So if the code description says with imaging guidance, you do not have the necessity to code the guidance code again. And CPT code 32408. So this describes the core needle biopsy of the lung or mediastinum with imaging guidance. So what is the rule one here? You have to report once per lesion. So one lesion biopsy, you have to report 32408 into one time. Two different lesions, you have to report 32408 into two times. And the rule 2 is imaging is included. So even if doctor uses CT plus ultrasound, you still report only 32408. There is no extra imaging codes. And the rule 3 is same session and same day. If multiple biopsies are done during the same procedure time, so coding depends upon the separate lesions but not the number of needle passes. So why this mediastinum is special? Because it's a space between the lungs. It contains heart, major vessels, lymph nodes, thymus. So because it's deep and risky, imaging guidance is always needed, which is why the code bundles it. Lung mediastinum biopsy coding special situations. So we are mainly dealing with 32408. So core needle biopsy of lung or mediastinum with imaging guidance and comparing it with core biopsies of the other organs like liver, CPT 47000. So FNA biopsies, fine needle aspiration. What is the scenario 1 here? Lung mediastinum biopsy, core biopsy plus core biopsy of the another organ in the same session. So what is an example? If doctor performs a CT guided core biopsy of the lung lesion and ultrasound guided core biopsy of the liver lesion, so what codes you have to assign? So you can report both biopsies. So you can report CT guided core biopsy for lung lesion as 32408 as well as ultrasound guide core biopsy of liver lesion. You can add or assign the code 47000 plus also imaging guidance code. So you can report both. You can also report the imaging guidance for the liver biopsy. You can append the modify 59 to the liver biopsy. Why? Because these are different anatomical sites. So 32408, it bundles the imaging only for the lung or mediastinum, not for other organs. And the scenario 2 is FNA plus core biopsy on the same lung lesion in the same session. So using the same type of imaging guidance. So for example, doctor does CT guided FNA of lung mass, CT guided core needle biopsy of the same lung mass. So what is the coding rule? You report both procedures, but you have to append modifier 52 to one of the biopsy codes. So why modify 52? Because imaging guidance was performed once. So both procedures use the same needle path and same guidance. So the second service required less additional work. So scenario 3. FNA biopsy plus core biopsy on the same lung lesion using different types of imaging guidance. So you have to report both biopsy codes here and you have to append the modifier 59 here. So why modify 59? Because there is a different imaging methods, distinct procedural service. So these are not bundled because the techniques are different here. And the scenario 4 is FNA of one lesion plus core biopsy of a different lesion within the same session and same imaging type. So you have to report both append modify 59 to one of the codes. Why? Because these are separate lesions and even though imaging type is the same, the procedures are performed in the different locations. So different lesion, distinct service, you have to append the modifier 59. Our next guidelines are regarding lung transplantation. So a lung allo transplantation, it involves, what does first lung allo transplantation mean? It means a lung from a cadaver donor is transplanted into a recipient. So the physician work is divided into three parts, three distinct components. So the first is cadaver donor pneumonectomy, donor surgery, that is organ removal. And the second is backbench work, organ preparation. And the third is recipient lung allotransplantation, recipient transplant surgery. So each part has separate CPT codes. So first is cadaver donor pneumonectomy. So this is the organ harvesting step. So what happens here? Surgeon removes the donor lungs from a deceased donor and preserve them. So surgeon includes removing one or both the lungs, flushing the lungs with cold preservation solution, coding and storing the organ to prevent the tissue damage. So these are done in this first step. And the CPT code regarding cadaver donor pneumonectomy is 32850. And this is very important because it is reported by the harvesting surgical team. It is not billed by the recipient surgeon unless they perform the harvest. And the second component is backbench work, organ preparation. So this happens after the lung is removed but before it is transplanted. So you have to think of this like an organ preparation on the table. So single lung preparation, the code is 32855 code. And what happens here? In a single lung preparation, you have preparation of one donor lung, including trimming extra tissue and preparing of the pulmonary veins, pulmonary artery and bronchus. Whereas in the case of double lung preparation, the CPT code is 32856. So preparation of both the donor lungs, same work as above, but it is a bilateral procedure. So backbench work is separate from transplant surgery because it requires additional surgical skill and time. It is billed by the surgeon who prepares the organ but not automatically included in the transplant code. And the third component is recipient lung allotransplantation. So the CPT code ranges are from 32851 to 32854. So this is the actual transplant surgery in the patient receiving the lung. So it includes removing diseased lungs, implanting the donor lungs, and connecting the pulmonary artery, pulmonary veins, bronchus, and managing patient during the surgery. So why these are separate codes? Because different surgeons or teams may perform donor harvest one hospital, backbench preparation the organ team, and transplant surgery recipient hospital. So each represents a distinct physical work. And here are some examples of the surgery section in respiratory system. So the first one is patient presented with hemoptysis and pulmonologist perform the bronchoscopy. So what happened here? Patient coughing up the blood. So doctor performed a diagnostic bronchoscopy with cell washing. So what is the correct code? CPT code 31622, which is assigned for the bronchoscopy, rigid or flexible, diagnostic, and also which includes the cell washing when performed. So why this code? Because this is a diagnostic procedure. The doctor has looked inside the airways, he collected the fluid or cells, that is washing, and did not take a biopsy or perform the treatment. Whereas in the example 2, established patient with SOB. So level 4 ENDM is performed, PA and lateral chest X-ray is done, diagnostic bronchoscopy with cell washing, and 2 bronchial biopsies are performed. So look, lots have happening here. So let's separate it first. The step 1 is E&M visit. So CPT code 99214 with modifier 25. It is used because the EMS is separately identifiable from the procedure. So doctor evaluated the shortness of breath before deciding on the bronchoscopy. And the step 2 is bronchoscopy with biopsy. So you have to assign the code 31625. And third question is chest X-ray. So this is separately reportable because imaging was done before as a part of evaluation but not bundled into a bronchoscopy. So you have to assign the CPT code 71020. And next example is third example, chest X-ray revealed atelectasis. So physician performed bronchoscopy and aspirated the fluid. So what happened here? Atelectasis. So atelectasis, it's a collapsed lung area which is often due to the mucus plug. So doctor performed bronchoscopy to remove the blockage. So the correct code is CPT code 31645, bronchoscopy with therapeutic aspiration of the tracheobronchial tree. So this is not the diagnostic, it's a treatment. So when bronchoscopy is done to remove the mucus, pus, blood clot or obstruction, it becomes therapeutic but not the diagnostic. And fourth example is diagnostic bronchoscopy and biopsy of two lobes. So what happened here? Physician performed bronchoscopy, took transbronchial lung biopsies and from two different lobes. So the codes are 31628. So bronchoscopy with transbronchial lung biopsy, single lobe. So report once for the first lobe. And 31632 for the additional lobe. So coding is based upon the number of lobes but not the number of tissue samples. And example 5, physician performed diagnostic bronchoscopy and visualized right and left lobes. So what happened here? The physician looked inside the airways, did the diagnostic exam only, no biopsy, no treatment. So 31622 code is assigned for diagnostic bronchoscopy with washing if performed. So right and left modifiers do not apply to bronchoscopy codes. Why? Because bronchoscopy is considered an exam of the entire tracheobronchial tree, not a site-specific organ like lungs in the surgery. So do not use modifiers RT, LT or 50. You have to only report 31622 once. And example 6, physician perform bronchoscopy biopsy with removal of the foreign body. So two different procedures happen during the same bronchoscopy session. So the procedure 1 is transbronchial lung biopsy, 31628 for biopsy of one lobe, and the procedure 2 is removal of the foreign body, 3163551 for the bronchoscopy with removal of foreign body, and you have to append the modifier 51 for multiple procedures. So why can both be reported? Because biopsy is diagnostic sampling, foreign body removal is a therapeutic intervention. So they are different procedural service. Neither is bundled into the other. So that's why you have to assign the code modifier 51. And here is an example. Surgeon uses VATS, take wedge biopsies of two lesions in the right lung, one in upper lobe and another in lower lobe. So the frozen sections results upper lobe lesion cancer and lower lobe lesion benign granuloma. So because cancer is found, surgeon proceeds with VATS for right upper lobectomy, removes the entire upper lobe and also mediastinal lymph node dissection. So this case includes diagnostic wedges, definitive cancer surgery and lymph node removal. So how do you code in step 1? You have to assign the code 32663 for thoracoscopy surgical with lobectomy. And step 2, 32668, which is an add-on code. So the surgeon performed a wedge biopsy to determine the diagnosis. And step 3, additional wedge resection. So this is also an add-on code. So this is used for the second lesion, separate lesion, second wedge granuloma. And step 4, mediastinal lymphadenectomy. So cancer surgery requires checking the lymph nodes. So plus 32674 is added. And next, If a biopsy is done to determine whether to proceed with major surgery, it is always a separately reportable code. So what are the add-on codes? Codes with a plus symbol. So do not need modify 51. They must be reported with the primary procedure. And here's the question, which is a direct laryngoscopy. So scenario described is patient sitting upright, tongue is pulled out, so warm laryngeal mirror placed at the back of the throat. So doctor uses head or mirror light to see the larynx. So answer is no. Why? This is directing a indirect laryngoscopy but not a direct laryngoscopy. Because laryngeal mirror is used. So this is used in the indirect laryngoscopy. And question 2, which does not describe the nasal septal surgery? So look at each option. 30420, it's rhinoplasty. It's a primary including major septal repair. And 30462, the second option, it's for cleft lip repair. And 30520, it's for septoplasty or submucous resection. This is a main septal surgery code. And 30930, it's a fractured nasal turbinate therapeutic. This is a turbinate surgery, but it's not a septal surgery. So the correct answer here is 30930. And question 3. Coding extensive cautery and packing for anterior epistaxis. So the key phrase is extensive cautery and packing. So you have to check the description. So 30903, the correct answer is 30903. It is for anterior complex and extensive cautery and or packing. So this is used when bleeding is harder to control, requires significant packing, more aggressive cautery, and it takes more time and skill. So fourth question is, a catheter is passed through a bronchoscope. Fluoroscopic guidance is done. A sterile brush inside a sealed catheter and brush advanced only after reaching the target area used to correct the culture. So what is described the technique called as protected brushing. So what is a protected brushing? It's a special sterile sampling method used during the bronchoscopy. So how does it work? It's a double sheeted catheter which protects the brush from the contamination. It is advanced into a specific lung area. The seal is broken only at the target site. So the brush collects the bacteria from the deep lung tissue. So this technique is used for diagnosing the pneumonia or a lung infection. And the last example is, which of the following is not a type of tissue as referenced in CPT code 31267? So the options are turbinates, polyps, mucous membrane, bony options and massive fungal corrections. So the correct answer is bony partition. So why it is bony partition? What counts as a tissue in this code? So tissue includes a soft, diseased or abnormal material such as, if a polyps, it is a abnormal soft tissue growth, mucous membrane, it's a sinus lining, massive fungal concretions, it's a fungal balls, inflamed tissue or a debris inside the sinus. So removing any of the above qualifies as tissue removal for CPT 31267. So why bony partitions does not count? Because bone is not equal to a tissue in CPT sinus coding. So bony partitions, these are the structural bones. So removing a bone is considered as a bone work but not a tissue removal. Bone removal may be a part of surgical access or it can get coded separately only if a distinct procedure is performed. So CPT sinuses or tissue removal codes are based upon the soft tissue but not the bone. So this is about today's session. I hope the session has helped you. So this is about the CPT guidelines regarding respiratory system. So the next session you will be able to learn the CPT coding guidelines regarding surgery of the cardiovascular system, which is in the 30K series. Thank you.